Good morning everyone and welcome to our first Virtual CPD Summer School. It's fantastic to have so many of you here this morning. My name is Charlotte Stevenson and I'm a Business Development Manager at the university. Two pieces of housekeeping before we get going this morning. We've got the chat function available this morning if you want to chat to the team. Any audio problems, anything you want to answer like that, use the chat function. And then we've got the Q&A if you want to pose any questions. We'll try and squeeze some questions in at the end of the first presentation, so just pop them in there and then we can ask them as we go along. We're all working from home, so please bear with us if there's any technical problems, talking while on mute, or interruptions from small children, animals, or delivery drivers. Enough from me. I'm really pleased to introduce our first speaker this morning. We've got Rupert Penwarden. Rupert is a consultant and superintendent radiographer. Over to you, Rupert.
Morning, everyone. I'll bring up my slides. Okay, everyone can see that. So yeah, my name's Rupert. I'm a consultant radiographer and I work at the West Middlesex University Hospital, which, to be honest, I hadn't heard of when I was sent here as a student many years ago, but it's situated in the west of London. It's quite near to Heathrow Airport. So just a bit of an overview of the hospital. It's part of the Chelsea and Westminster NHS Foundation Trust. They're the other sort of sister site within the trust. And the catchment for West Mid alone is around about 500,000 people, which is similar to urban Cardiff. So it gives you an idea of how many people are sort of within our remit. The hospital isn't particularly huge. We've got 5 X-ray rooms, a couple of fluoroscopy suites, a couple of CT scanners. If we were to compare it to other hospitals that you may have worked at, one of the slight issues we have is that our X-ray department is in one place. We don't have a separate A&E and a separate general, so it does mean that everyone is coming to the same part of the hospital, which when we've been trying to split patients that we think may have COVID-19 from ones that don't, it does create some logistical problems, but we've worked around that. So a few things to consider about this hospital is that it is in London, so the population density is really very high, which is known to be a means to have greater transmission rates. And this part of London, there's a lot of ethnic diversity, and there's a high proportion of people from backgrounds that have been since shown to be more at risk of COVID-19. So it kind of creates an environment where we're likely to have more patients than other similar sized hospitals in other parts of the country. So what would I normally be doing? So say in January of this year, my work looked very different to what it does now. So I do quite a lot of fluoroscopy studies in the role of a radiologist. So I do barium swallows and mills. I do some proctograms, and I also help out with things like video fluoroscopy swallows to help with speech and language assessments, as well as really just being an expert practitioner in intervention as well. And that takes up probably about a day a week of my time normally. And then I also do X-ray reporting. At the minute, that's just skeletal, but really for any age group, the only things I don't really report for that are skeletal surveys for non-accidental injury. And that sees me reporting over 1,000 plain films a month. So if you add those two together, that's taking up a fair bit of time. Then there's meant to be a time commitment whilst I'm at work to do studies. I'm actually a student at Cardiff University doing adult chest and abdomen reporting. It's a really good course. I'm really enjoying it. Brilliant teaching. In addition to that, I'm mentoring radiology registrars and reporting radiographers. Outside of the reporting role, I'm obviously doing a lot of other sort of conventional radiographic work. So I might be in CT sometimes, I could be taking x-rays on the ward. But typically I'm in the department. And sort of what I would say is that overall, normally my reporting workload is about 50% of my working time. So what was the impact from coronavirus for me at this hospital, or at least on the hospital? So the image on the right is actually a photograph taken out of this hospital. So the hospital was featured in the Sunday Times. You can still access that on the website. It's a good read. It's quite emotional, to be honest. But what happened for us? So this is really what happened in most hospitals right across the UK. So all non-emergency work was put on hold. Initially, that really went right across the board. So we were really just working via A&E and via the wards. Obviously, one thing we want to try and do whenever there's a patient that could or does have coronavirus is minimise the risk of that being transmitted to anyone else. So whereas normally we would bring the vast majority of the patients that require X-ray imaging down to the department, instead we went to see them wherever they were, whether that be in A&E on the ward. So our portable X-ray workload went up about 7-fold. So I think at the height we were doing about 80 mobiles within a 24-hour period, which for this site is quite a lot. It may not be huge numbers compared to other hospitals, but for our team that's a hell of a lot of work. There was a much bigger demand on imaging out of hours. If you can imagine patients attending that need immediate care, it doesn't sit well with conventional working time. They could attend at any time of the day or night, or patients on the ward could become acute or critical at any particular time. What we did see was just a general decrease in the volume of X-rays and CTs that were being performed. But each examination takes much longer, partly because most of them require at least 2 people to perform. You'll try to have one of the staff members stay as clean as possible and one that's more involved with the patient. And obviously, there's a lot of cleaning that goes on. So obviously, there's normal cleaning we would perform. But in these instances, there was a lot of cleaning with chlorine on the equipment. the regulations and recommendations were changing on a daily basis. But for example, you would need to get the room what we would call a COVID clean, which would normally involve calling in the cleaners. And we found that that really was hindering us. So in the end, we took over those duties. So we would do the mopping of the floor and everything else. On top of that, we had quite a number of our staff show symptoms. Some of them were even admitted to hospital, and at times we had as many as a quarter of the radiographers in the hospital off sick. So really what this all led to was a greatly increased demand on radiographers, but a reduced number of images that need reporting. So how did my X-ray reporting change? So like I said, the demands on it really went down, and you need to bear in mind that whilst the demands on the radiographers went up, because we were performing less studies, the demand that is conventionally associated with radiologists of reporting went down. So really what happened is where I would normally fit in to try and help out with the radiologist, that really wasn't as necessary anymore. So my plain X-ray reporting diminished quite drastically. Instead, I would be out far more often with the teams on the ward or running the CT scanner. So for the first 2 weeks, I was running the CT scanner. Then I was more heavily involved with going up to the wards, and we would spend often over an hour in one of the red or green zones imaging patients. It was fairly typical that if you're in A&E, you might go to X-ray 1 or 2 patients, and by the time you've seen those 2, there's another patient that needs an image, then there's another one, and what would have been maybe a 10 or 15 minute session ends up being over an hour. So in addition to all of that kind of conventional work, there's obviously a need to support the staff. As is common in most radiology departments, we have quite a number of staff that have qualified in the last few years, and they've really never seen anything like this whatsoever. A lot of them don't necessarily live with their family, and you can imagine how sort of scared they may have been, and how the normal support mechanisms that would be in place weren't possible, as they couldn't go and see their family for the support there. So there was quite a sort of large element of making sure everyone was all right, trying to support people as best as we can. We had to redesign a number of patient pathways, like I said, trying to minimise the chance of red and green pathways crossing. And on top of that, just not needing to X-ray as many patients. So a couple of my staff are on the image, that's them in the A&E department. Thankfully, we have 2 digital mobile machines, and they proved extremely valuable. The time of going around with AMX4s and performing X-rays on CR or film, this would have been very, very difficult at the moment. So we're very lucky to have those pieces of equipment available to us. That being said, my GI fluoroscopy workload actually increased. And the main reason being is that for most hospitals, a lot of their patients that have trouble with swallowing, dysphagia, will be seen by endoscopy, and they perform OGD, so endoscopic assessment of the esophagus and the stomach. Now, that procedure is fairly risky. You know, there's debate about whether it generates aerosol or not, but certainly it's very typical that the patients will cough and choke whilst the scope's being put down into the stomach. So the provision for that was greatly reduced. So what we saw was much greater numbers of barium swallows and mills being requested for patients that could potentially have cancer. And as it turned out, normally what would happen is those deemed most likely to have cancer would have OGD performed, because then they can biopsy any abnormal areas of mucosa. But because they weren't doing that, it meant that we saw those more at-risk patients. And subsequently, there's been a greater number of esophageal and gastric cancers diagnosed via fluoroscopy than normal. The video fluoroscopy service was reduced massively, only for the most critical patients, often people that have been taken off ventilation, and the proctogram service, given that it's not anything to do with cancer, is just on hold, and it remains on hold at the moment. So I did say before that I'm a student at the moment. So what really happened about my studies? Well, it's very difficult at the moment to fit in that time within hours. There's meant to be a set number each week that I get to do within my contractual hours, but fundamentally it's too busy to do that at the moment. What I would say is that because we're going up to take lots of chest radiographs, there's obviously an opportunity there to do your hot review of the images, and then afterwards compare that with what the radiologists have written. So what I would say is it's trying to make the best out of a challenging situation. So thankfully I was ahead with the coursework, which is good because historically I've not been great at doing that. So anyone that is still studying, it's always worth getting ahead with your coursework because you never really know what might be around the corner. So I thought we'd go and just talk through a few cases. It's only 3. They're all anonymized. So this is the first patient. So this was one of the radiographs they had taken whilst they were on the high dependency unit. So this is one our DR mobile. So what we can see, unfortunately, the radiograph is slightly rotated, and obviously that's a problem because it does distort how the chest looks. But this patient's got bilateral peripheral consolidation, and that is sort of the classic COVID-19 appearance on a chest radiograph. They don't have a pleural effusion. If someone has a pleural effusion, that's unlikely to be COVID-19 related. And this patient was confirmed to have COVID-19 long before this chest x-ray was taken. But just to give you an idea, this is what the chest x-ray may look like on ITU. The patient's got an NG tube in, they've got a tracheostomy tube, and they've got a CVC line. So this patient is being ventilated, and obviously you've probably seen a lot in the news talking about the benefits and the risks of ventilation. Ventilation itself is not really treating the patient. The idea is just to aid with the getting oxygen to the body whilst the body itself fights off the virus. Now, one of the complications of that is it puts a lot of pressure through the lungs. So the next image, it's the same patient. This is a CT scan taken 1 day after the chest radiograph. And what we can see, some of you may not have seen a huge number of CT scans, but where we've got normal lung here, at the apex, we've got just black. This is a pneumothorax. We've also got air around the mediastinum, and there's air within the soft tissue. So this patient's got a pneumothorax secondary to ventilation, which is a problem that would have been seen at pretty much every hospital around the country where ventilation was being performed. And it's just something that has to be managed. So, you know, ventilation in itself isn't a guaranteed help to a patient, and it has to be used when deemed appropriate by the anaesthetic teams. Going back to that patient is actually getting better, is no longer on ITU and hopefully discharged soon. This patient came in, you can see it's around 8 o'clock at night. This was on a Thursday, so just before the clapping. This patient came into resus. This was their first radiograph. I took this. And what you can see is that they've got the defibrillator pads on. You know, this patient was ill enough that they weren't sure if they would arrest there and then in resus. They were on CPAP, but the ventilation was only around 70%, so they were really struggling. And once again, we can see this bilateral consolidation within the lungs. This patient's lungs were affected enough badly that ventilation wasn't an option. So the ECMO procedure was performed, and then this patient was taken to one of the 5 ECMO centres in the UK. So anyone not familiar with ECMO, this is really a way to bypass gaseous exchange within the lungs. So blood is taken out of the body, oxygen's put into that blood, and that blood's put back into the body. It's a bit of a final attempt to try to stabilise the patient. So that's what this is. What the ECMO machine can look like. So that patient was taken to another hospital. And then the last case, this patient came in, again, this is a radiograph in resus, and there's the bilateral peripheral consolidation typical of COVID-19. Quite a young patient, as you can tell from the skeleton. But this is their radiograph 2 months later on intensive care. So you can see that some patients, it really does take a long time for them to improve. And again, we've got a pneumothorax on the left side. So there's the edge of the lung and now air within the pleural space. So again, another example of some of the dangers associated with ventilation. That patient is recovering, thankfully. So I'm not sure if I was too quick or too slow, but that's all the slides. So has anyone got any questions?
If anyone's got any, if anybody's got any questions, you can type them into the Q&A and we can ask Rupert to answer them. We've also got some of the radiography team from Cardiff University on the webinar as well. So if anybody's got any questions, please type them in and we can ask away. If not, we have got a pre-recorded presentation for you next by Dr. Christina Malamateniou. I hope I pronounced that correct. And she's the director of the postgraduate and doctorate program at City University. We'll just hang on a sec just to see if there's any questions. Anybody's coming. I think everybody's probably digesting all that information already. Rupert, are you happy to hang around on the Zoom until the?
Yeah, absolutely. Absolutely.
Okay, so if anybody puts out questions in, either to Rupert or the team, we'll play the next presentation by Dr. Christina now, and then you've got time then to type in your questions for the end. Okay, we'll play the next presentation.
Good morning, everyone. My name is Dr. Christina Malamateniou. I am the director of the postgraduate and doctorate program at City University in radiography.
Apologies, let me start that again. Bear with me. Sorry. Okay. Here we go.
Good morning, everyone. My name is Dr. Christina Malamateniou. I am the director of the postgraduate and doctorate program at City University in radiography. I was invited by Radiography department in Cardiff University to talk about COVID-19 and what radiographers need to know. I'm really grateful to Cardiff University for this invitation. The reason I was invited is because I have recently submitted a paper in the Radiography Journal on COVID-19 with the same title, What Radiographers Need to Know. We all know that COVID-19 is indeed a pandemic, and numbers of cases and deaths are increasing nationally and internationally. There are more than 9 million cases now confirmed in the world of COVID-19 and more than 470,000 deaths. Similarly, there are more than 300,000 confirmed cases in the UK and more than 42,000 deaths. The virus has originated in the Hubei region of China, and then it has traveled to Europe, Italy, where it spread to other European countries, and from there to the whole of the world. As you can see on this map from Johns Hopkins University, you can see that there is a widespread of the coronavirus in all of the developed and parts of the developing world. The paper we have submitted in early May in Radiography Journal is titled COVID-19 in the Radiology Department, What Radiographers Need to Know. And this is exactly the reason we have written this paper. In our position as academics, we wanted to help our colleagues working clinically on the front line by gathering all the available evidence at the time and helping them making decisions, protect the patients and protect themselves in clinical practice. My co-authors are Dr. Dimitris Fotopoulos, who is a radiologist in the northwest of England, Dr. Nikos Nitsa, who is a clinical academic radiographer, and Mr. Nikos Stoyanos, who is also a clinical radiographer. When we submitted the paper, we were hoping that it would be a very, very useful resource for our radiography colleagues working on the front line. And indeed, many of the radiographers now in the UK and in the world work on the front line, as they are often amongst the first healthcare professionals who are faced with caring for and imaging COVID-19 patients, either confirmed or unconfirmed. So we are pleased to see that our paper now is listed as the most read paper in the Radiography Journal, as of recent measurements have highlighted. This paper is now available as a full text online because it's about COVID-19 and there is no need for you to have subscription. You will find the link of the paper at the end of this presentation. So the aim of this paper was to review current literature related to the diagnosis, management and follow-up of suspected and confirmed COVID-19 cases, and to understand the role of the radiographers in imaging, patient care and patient and staff safety. In terms of the diagnostic workup used to confirm a COVID-19 patient as positive to COVID-19, there are three different ways to do so. One is the nasopharyngeal swabs. There are different tests for that. These are all viral tests, not to be confused with antibody testing, where this is requiring a blood sample. There are different names like RT-PCR, real-time RT-PCR, and reverse transcription loop-mediated isothermal amplifications, or RT-LAMP. And they're all using a sample from either the nose or the pharynx. There are also blood tests where people test for different values of the differentiated white cell count, C-reactive protein or CRP, D-dimer and erythrocyte sedimentation rate or ESR, and also lymphopenia and mildly elevated CRP have been widely reported as a risk factor for more severe disease. Finally, imaging is used as a complementary tool to diagnosis, either when all of the above are not available, or because sometimes they might have a lower sensitivity or specificity to COVID-19, we could use imaging for final confirmation. In terms of what is available from the imaging arsenal, if you want to detect COVID-19 and radiological findings, people have used chest x-rays as a first-line tool, really. And then a CT chest to, particularly for more severe cases, to differentiate from other types of pneumonia. Point-of-care chest ultrasound, this is becoming now increasingly popular, but at the time of the review, it was not considered as a main imaging tool. And also, as we understand more about the neurological and neuromuscular complications of COVID-19, MRI also has a role in delineating these complications and supporting treatment plans and the patient pathway. The major radiological findings of COVID-19 include ground glass opacities, consolidations and bilateral interstitial opacifications. Pneumothorax or lung capitations are not common complications. And of course, all these imaging appearances may vary with the stage of the disease, the start of the initial symptoms, and the disease severity. Many of the chest x-rays can be normal in early cases. So when someone comes really early and has a confirmed COVID-19, early in the infection or in mild disease, a chest x-ray might be absolutely normal. In severe COVID-19, there is a proportionately greater lung involvement, which tends to be denser in the periphery and in the lower lung zones. These are all chest x-rays from left to right with increasing severity of the imaging manifestations of COVID-19, and you can see gradually the black color, which indicates air-filled cavities in the lungs, to be replaced by a whiter color, which signifies opacification but also consolidations in the lungs. And the patient on the right is the one who has a more severe manifestation of the COVID-19 disease, as indicated by their chest x-rays. While a chest x-ray remains, because of its availability, low cost, and the time that it takes to be produced, it remains the first-line imaging tool for any lung disease, including COVID-19. Chest CT has a limited but very important role in the clinical management of COVID-19 patients. Many of the different guidelines suggest that CT chest should be reserved only for the seriously ill patients when there is increasing awareness of a high prevalence of or possibility of pulmonary thrombosis, because this has been classified as a complication of COVID-19, and many of the patients who have died from thrombotic episodes. In addition, it can be used in the case of inconclusive chest radiographs or unavailability of the swab tests. In the case of follow-up imaging, where CT is required for a clinical decision-making, as a clinical decision-making tool, a low-dose chest CT may be considered, as it can offer up to an 8-fold dose reduction. These are some actual images of CT chest in a COVID-19 patient. You can see the different manifestations of the COVID-19 disease from pictures A, B, C, and D. And the arrows show respectively on A, the ground glass opacities, on B, consolidations, on C, consolidations with ground glass opacities, and D, a solid nodule, as manifestations of COVID-19. While CT chest and chest x-rays have well-documented sensitivity and specificity for already well-described pneumonias, their sensitivity and specificity for COVID-19 pneumonia is not well established. There are some studies from different countries using different protocols and different kinds of equipment, but trying to bring those together, we have identified that the sensitivity of a chest radiograph, chest x-ray, varies from 50 to 84%, which can be quite low, because it means it fails to detect 16% of those who indeed have COVID-19. The specificity is not easy to calculate because there is insufficient data where the normal cases are lacking, and it's not very easy always to do that without normal cases. For chest CT, there is higher sensitivity ranging between 61% to 97–98%. And the specificity again is quite low, which means that some people might be, on the basis of their CT chest only, diagnosed as having COVID-19, where they are not. And for the lung ultrasound, there was only one study available, but I'm sure as we speak and discuss further, there is more lung ultrasound happening at the point of care, on the bedside, and the sensitivity and specificity of that study showed really high percentages for a lung ultrasound. There have been many societies and we append at the end some of the links you can see here where you can go and study further about best practice guidelines in relation to imaging patients with COVID-19. The American College of Radiology is amongst those who is more conservative as far as it is concerned about imaging. They don't recommend imaging unless it is clinically indicated and is going to have an impact on management. Otherwise, they trust for the diagnosis the swab tests or blood tests. The British Society of Thoracic Imaging also says that imaging, either chest X-ray or chest CT, must be reserved only for the critically ill patients. And lung ultrasound can be used as a monitoring tool for only, again, for these critically ill patients at the bedside. There are other societies and professional bodies, and you can find all the information you need to see what every country suggests. The Fleischner Society is an international consortium of medical imaging professionals for the lungs, and they tried to bring together expertise from around the world in this field. Again, they align with the previous societies and professional bodies, recommending either chest X-ray or chest CT, only for patients who really need it, not for those with mild symptoms, but only for the critically ill patients. There is a lot to learn and a lot to do as far as the safety in the radiology department is concerned, for patients, for medical staff, and also for protecting the department and the environment. And you can read about all of that in this paper, about cleaning the equipment, how the patient should present in a radiology department, how medical staff, radiographers should be protected in their protective equipment, and how to disinfect a scanner or an imaging piece of equipment for the next patient, so it's safe for them and there is no cross-contamination. There is a differentiation of the personal protective equipment advice in relation to which department one works in. So for those who are having a general contact with confirmed or possible COVID-19 cases, you can see the related piece of equipment, protective equipment on the left with this orange color highlighted in orange. And then you can see for those who actually generate procedures of high-risk areas where there are confirmed cases of COVID-19 patients, and there might be aerosol generating procedures, for instance, cuffing, active cuff. So you can see the requirements are much stricter, and you can see those as green, in green highlighting on the right. In conclusion, from putting together all this piece of information, medical imaging plays an important auxiliary role in the diagnosis of COVID-19 patients, mainly for those who are most seriously affected from the disease. And although practice may differ widely among different countries, from China to Italy to the UK and the US, which is mainly due to the variability of the access to resources like viral testing and imaging equipment, specialized staff like radiographers and protective equipment, overall, what is discussed is that all imaging should be reserved for those who are more critically ill or for those where a treatment decision, management decision has to be made urgently. Chest radiograph should be the first-line imaging tool if we have to go into imaging, and chest CT should be reserved only for the critically ill patients or when the chest X-ray or their clinical presentation may be inconclusive. Also, as radiographers work on the front line, they should be aware of the potential risks associated with COVID-19 and engage in optimal strategies to reduce these risks for themselves and also for their patients. Their role in vetting, conducting, and often reporting the imaging examination is vital, as well as their contribution in patient safety and patient care. Medical imaging should be limited to critically ill patients and where it may have an impact on the patient management plan. In terms of implications for practice, well, I guess it's common knowledge now that we cannot do things as we have been doing things before, and this accounts for radiography, but for many other clinical practices. We have to adjust to these new requirements for stricter and more stringent infection control to support optimal and safe imaging practices for the diagnosis of COVID-19. And as CT might be happening more often to help with differential diagnosis and establishing a diagnosis of COVID-19 and management plans, it's important to adopt a low-dose CT, rigorous infection control protocols, and optimal use of personal protective equipment to reduce any risks of radiation exposure, infection, respectively, within radiology departments for radiographers, but also for other staff. If you want to learn more about imaging for COVID-19 patients, please visit the first web link we append here, copy and paste on a web browser, and this is the paper, our paper in radiography. There are also many useful resources in the Society and College of Radiographers, so this is the second link. In the International Society of Radiographers and Radiological Technologies, there's a whole link about e-learning for COVID-19. There is a Royal College of Radiologists as well, COVID-19 resources, and the British Society of Thoracic Imaging, where they have some clinical guidelines for the reporting radiologists, but also for all medical imaging professionals. Thank you very much for listening to this talk. I hope you enjoy the rest of the summer school. And if you have any queries or any questions about the paper or COVID-19 in medical imaging, please email me at this email address or contact Charlotte or Gareth so they can liaise with me and we can discuss further. Thank you very much.
Right. There we go, back on. We've had a couple of questions come in, which I can pose to Rupert and to our radiography team. Would there be a need for permanent change in the configuration of radiology departments in post-COVID-19 with more innovative ideas?
I think so. I mean, I touched on it briefly in my talk that it's preferable to have more than one X-ray department within the hospital, so that should a problem like this occur again, you can have an area where you try to separate elective work from emergency work. That's definitely important. And what I would say is that certainly one of the things that we can learn from this experience is that there's definitely an opportunity to try to improve the standard for vetting of requests to make sure that only the really necessary examinations are happening, because at the minute the demand is greater than capacity, and that isn't necessarily a new thing, but this is a more critical example of that, and that's certainly a way to go forward. I would say that generally unfortunately there's a lack of equipment within hospitals and a lack of radiographic staff as well, so that isn't necessarily a new thing, but going forwards, you know, the profession, arguably there should be more radiographers and therefore more equipment for us to use, because demand is such a big problem, and it has been for at least the last 15 years.
Thank you, Rupert. Have the skills and training that a radiographer needs changed or will change in this post-COVID-19 world?
I've thought about that, and to be honest with you, I felt that certainly our staff that have only qualified in the last year or so have coped admirably. From a technical perspective, there hasn't really been any problem with what they've been doing, and they performed extremely well. I think the thing that they weren't necessarily prepared for was the emotional aspect of things, and I think it's very, very difficult to prepare people for something like this. I certainly was not necessarily that well prepared, even though I've previously experienced other pandemics in the last 15 years. Otherwise, fundamentally, we are still performing what we're trained to do, which is to image patients to a high standard as the core aspect of diagnostic radiography. So I don't see there being a problem with the training.
More of maybe a personal question from somebody. What is the most stressful situation you've experienced? They haven't said whether that's in this current situation or throughout your career, so take your pick.
Probably throughout my career, I would say the first time I sat the skeletal reporting exams, I failed by 1 mark. So that was very stressful because the retake, you only get 1 chance to retake. So I really hope I don't have the same problem with the exams that are coming at Cardiff. But I would say throughout this coronavirus pandemic, to be honest with you, what I found more difficult is the recovery phase, because there's so much planning that goes into now trying to catch back up with work that we had to put on hold. The actual sort of most severe part of the pandemic we've experienced so far, I didn't find particularly stressful. I guess because fundamentally we're doing what we're trained to do. So for me, it wasn't such a problem, but I know a lot of staff found it obviously was emotional, but I've been qualified for quite a long time, so I've seen a lot of sad things, unfortunately. But yeah.
Okay, and one last question, unless anybody else wants to quickly type one in. How much impact, I think this may have been covered slightly in Christina's presentation, but how much impact has PPE had in the role of the radiologist and your ability to carry out?
Mm-hmm. Yeah, I mean, it's certainly been in the press a lot about, are there shortages? I'm very thankful to say that we've never experienced a time when we ran out of PPE. I would hate to be in a position where we had to make a decision as to what to do then. I know the society were very clear with their instructions around if that ever occurred, but thankfully it didn't here. What I would say is that the guidance did change quite drastically over the first few weeks. So initially it was meant to be FFP3 masks for confirmed cases, and that has gradually changed to the stand now. So what I would say is that the fundamental important part is that there should be regular briefings with staff so that all the staff are up to date with any sudden changes. So we have a daily meeting of the team where we can discuss any changes that have happened in the last 24 hours so that everyone's up to date. Because certainly I think what we've done well is we've managed our PPE well, because it is a vital resource, so it needs to be used well if we're going to not run out of it.
And one last one, which I may get completely wrong. I'm not a radiologist, so bear with me. Were you requested to image patients PA in the prone position? The prone position? Okay,
yeah. So this question is referring to patients that really had quite severe lung infiltration and problems ventilating. They would place some of these patients prone. It means that the posterior aspect of the lung becomes non-dependent, and that air is bigger, so it should help get more air into the lungs and oxygen into the blood. We didn't do much prone imaging, to be honest with you, but we did do some. Obviously, our conventional chest radiograph is performed PA. All I would say is that the real difficulties with prone imaging is related to maintaining the airway and making sure that there's no issues with ventilation. So what's vital is that we work closely with the teams on the ward, i.e. the anaesthetists and the specialist nurses, to make sure that we never do anything that endangers the safety of the airway. So it's all about communication really, and making sure that everyone knows what's about to happen when the patient is moved and the plate is put in place. We may have done, I would say, less than 10 prone radiographs. Bear in mind the patients generally get rotated from prone into supine. So generally what we would do is if we came across that, we would rotate the patient round. It's all about communication with the team. It also depends on what they're looking for. So yeah, we did some, but not a huge number.
Thank you very much. I think we've kind of reached the end of our talk this morning. I just want to take a few minutes to say thank you for all attending. I hope you got a lot out of it. There's a lot of information in there. I'd like to thank our fantastic speakers, Christina, who sent in a pre-recorded one, and to Rupert this morning for taking all those questions on his own this morning.
No problem.
And also, to the radiology team at Cardiff University for helping put this session together. Yeah, have a good rest of the day, people. Take care.